Hello, we're going to continue our movement disorders series. And today we're going to talk about non-PD Parkinsonism. This would include a group of conditions under atypical Parkinsonism and also a few conditions under secondary Parkinsonism and also hereditary Parkinsonism. We're going to start it with progressive supranuclear palsy, PSP, and this is a condition derives its name from progressive impairment of voluntary vertical gaze. Has a prevalence of about 6 per 100,000 population with a median age of onset in middle 60s, so similar to Parkinson's disease. Typically, patients present with a kinetic rigid syndrome of Parkinsonism with early loss of posture instability and causing frequent falls. Typically, the falls would be backwards, falling backwards. As the disease progresses, supranuclear palsy becomes much more apparent, and patients eventually develop spasticity, dystonia, dysarthria, dysphagia, and a subcortical frontal dementia syndrome. And a typical patient with PSP would develop incapacity usually occurs within 3 to 5 years, and death within 6 to 8 years. Generally as a result of aspiration, infection, or complication of immobility, such as fracture. And this is a typical MRI findings of a patient with PSP showing very significant atrophy of the midbrain structure, and with hummingbird appearance. You can see the hummingbird bird, and this is looks like the head of a hummingbird, and this is the most characteristic feature of a PSP. If you see that on MRI, it's quite possible the patient is PSP in the correct clinical setting. A type of abnormally accumulated protein and as part of neurodegeneration. The typical tau is then globulous neurofibrillary tangles with tufted astrocytes. And PSP usually has increased ratio of 4 repeats versus 3 repeats microtubule associated protein tau as protein isoforms. Multiple system atrophy is another atypical Parkinsonian syndrome and characterized by different presentation of Parkinsonism, cerebellar ataxia, and spasticity, and a significant autonomic dysfunction. The key feature for MSA is, oftentimes patient presented and with predominant autonomic dysfunction, including orthostatic hypotension, urinary incontinence, and urgency. The typical prevalence of MSA is 2 to 4 per 100,000 population, and the median age of onset is a little bit younger than PSP and Parkinson's disease, is around 55 years old. And men is more common with MSA than women. The mean survival time is similar to PSP, 6 to 9 years. Half of patients disabled or wheelchair bound within 5 years of onset of motor symptoms, typically because of significant orthostatic hypotension. They just cannot get up and without getting, dizziness, lightheadedness, or blackout. There are 2 subtypes of MSA, including MSAP, which is a progressive Parkinsonism poorly responsive to levodopa with significant autonomic failure, including orthostatic hypotension, impotence, and bladder dysfunction. typically the age of onset is older than 40 years old. The disease duration is less than 10 years. The other subtype is MSAC, the multiple system atrophy cerebellar type, and usually present with ataxia and degeneration of ventral pons, olivus, cerebellum, with mild Parkinsonian features. This is a typical MRI imaging finding in a patient with MSA with predominant cerebellum ataxia, and you can see there is significant atrophy in the cerebellum and also, atrophy in the brainstem with selective loss of myelinated pontine transverse fibers, which gives a feature of hard cross-bond signs similar to the hard cross-bond. This is very characteristic for MSA. Pathologically, MSA can be defined by, neuronal loss and gliosis in at least 3 of the following structures, including striatum, substantia nigra, pontine, metacerebral peduncle, and cerebellar Purkinje cells, inferior olivar, and the intermediate lateral cell columns. And it is conditions caused by gliosis and with gliocytoplasma encroaching in the astrocytes, and which is different than Parkinson's disease, dopaminergic neuron involvement. MSA is also considered alpha-synucleinopathy, means there is a pathologic deposition of abnormal alpha-synuclein in the cytoplasmic inclusion. I'm going to switch to corticobasal degeneration, and this is a condition with a prevalence of about 5 to 7 and 100,000 population, with a median age of onset in 60s to 70s. Survival time is about 7 years old, and typically patient present with insidious onset and progressive of asymmetric cortical and basal gangliotic features. And remember, CBD can be very asymmetric and with the presentation, and this typically including asymmetric Parkinsonia feature, asymmetric tremor, dystonia, or myoclonus. Because of a significant cortical dysfunction, patient can present with the alien limb phenomenon. In this case, patient feel like one side of their limb is out of their own control and not attached to their body and can act on its own. Other cortical dysfunction including dementia, speech impairment, and cortical sensory disturbance. This is again a typical MRI imaging finding of corticobasal degeneration, showing a significant frontal parietal occipital atrophy on the left hemisphere of the brain compared to the right side. You can imagine this patient probably have asymmetric motor sensory symptoms on the right side of the body. And the CBD pathology, it's widespread neurodegeneration in cortex, basal ganglia, thalamus, and other structures. And again, it's similar to PSP. It's 4 repeats, predominant tau and apathy, and causing astrocytic plaques and corticobasal inclusions. Baroon neurons with diffuse cytoplasmic immunoreactivity to crystalline and ubiquitin are the common features of CBD pathology. The management of PSP, MSA, and CBD is basically based on what symptoms they have, because overall there's no specific treatment for either of those conditions. And clinicians typically use levodopa for the Parkinsonian features of MSA, PSP, and CBD, but usually the response is very poor, And then there's also a lot of other, symptomatic treatment, and depends on what's the predominant symptoms of those patients. And I'm gonna skip this slide. And we're going to talk a little bit about secondary Parkinsonism. This includes vascular Parkinsonism, drug-induced Parkinsonism, and normal pressure hydrocephalus. Vascular Parkinsonism is caused by usually a stroke in basal ganglia or much more widespread subcortical white matter chronic lesions. And the typical vascular Parkinsonism present acutely or subacutely with the stepwise evolution of akinesia and rigidity. The prominent posture instability and the gait disorder give vascular Parkinsonism a name, the so-called lower body Parkinsonism. That means in those patients have a shuffling gait and with posture instability, but usually their upper extremity function is well. There's no tremor, not much tremor, rigidity, or bradykinesia in upper extremity. And vascular Parkinsonism typically doesn't respond well to levodopa as well. Normal pressure hydrocephalus is a condition, it's a syndrome caused by a combination of, present with a combination of gait disturbance, urinary incontinence, and dementia. On imaging, you can see dilated ventricles, which is disproportionate to cortical atrophy. And there's also some small vessel ischemic change along the ventricles. To confirm the diagnosis or to confirm if the patient actually has a good treatment is by doing a large volume cerebrospinal fluid, drainage. This is the so-called large volume lumbar puncture, and to remove at least the 30 cc of cerebrospinal fluids. And once the fluid's been removed, usually because of the pressure change inside the ventricle, you will see sometimes significant improvement of the patient's gait and walking. That's the indication that the patient may be a good candidate for a procedure called ventricular peritoneal shunt. And the procedure is to shunt the cerebrospinal fluids from the ventricle to the peritoneal space in order to bypass the accumulation of CSF and the pressure buildup. Drug-induced Parkinsonism is caused by exposure to dopamine receptor blocking agents and the so-called antipsychotics or occasionally antiemetics. And the typical presentation is bradykinesia, rigidity, and some tremor. Oftentimes, the patient can present the so-called rapid syndrome, means there's involuntary dyskinesia movement around the mouth, mimicking, a rabbit is chewing. And the nature of the rabbit syndrome is tardive dyskinesia, and which commonly can be seen in patients taking antipsychotics as well. Mild case of drug-induced Parkinsonism can frequently remit after cessation of the offending drug and usually unresponsive to dopaminergic therapy. Keep in mind that the elderly patients are much more susceptible to antipsychotics and are much easier to develop drug-induced Parkinsonism. We're going to touch base a little bit about the hereditary Parkinsonism, and including mainly Huntington's disease and Wilson's disease. Huntington's disease is a hereditary neurodegenerative disorder. The Huntington gene is located in the 4th chromosome, and the mutation of the Huntington gene causes trinucleotide CAG repeats. This repeats and will transfer to abnormal Huntington protein with excessive number of glutamine units, the so-called poly G units. The clinical features of Huntington's disease can be, predominantly motor features, including, chorea, involuntary movement, dystonia, McLaren's, and motor persistence and gait disorder. Later on, Huntington's disease can develop Parkinsonism as well. And HD patients can also manifest as psychiatric symptoms, including personality change, affective disorder, obsessive compulsive disorder, and psychosis, really. Cognitive impairment, including executive dysfunction and dementia, can be very common in HD. And this is a typical MRI findings of HD showing significant atrophy of head of caudate, and while comparing to a normal head of caudate in a normal subject. Pathologically, HD patient's brain usually smaller with atrophy, with prominent atrophy of the caudate nucleus and the putamen, and also include the atrophy of the frontal lobe and other part of the brain. Microscopically, there is significant striatal neuronal loss and gliosis, particularly medium spinning neurons. In remaining striatal neurons and in the cortex, there is an internuclear inclusion that contains aggregates of Huntington protein as the inclusion body. The management of HD, including multiple disciplinary approach, including genetic counseling, symptomatic treatment of motor psychiatric cognitive symptoms, and psychosocial intervention. Disease-modifying medication is an active area of research, but not available now. And symptomatic treatment of HD, including treating the chorea by using VMAT2 inhibitor. This included tetrabenazine, deutetrabenazine. We're gonna, explain what's VMAT2 inhibitor later on. Amantadine has been used. Remember we use amantadine for Parkinson's disease to treat the dyskinesia. Here it can help the chorea to some degree as well. Traditionally, neuroleptics such as Hypno, Risperdal has been used to treat chorea symptoms of HD as well. There's different treatment for psychiatric and behavior symptoms of HD, including environmental change, SSRIs, and typical and atypical antipsychotics for aggressiveness and irritability, and mood stabilizers. There's no good treatment for the cognitive impairment of HD. This slide explains what's VMAT2, what's the VMAT2 inhibitors. VMAT stands for vesicular monoamine transporter, and it's an enzyme and transporter protein located in the presynaptic dopaminergic neuron and nerve ends. And the function of the VMAT is to remember, and dopamine got released to the synapse. After a while, it can be reuptake by dopamine transporter. And in the presynaptic dopaminergic neurons, it's spiked by the VMAT protein to these small vesicles and then get released back to the synapse. Think about if you have a VMAT2 inhibitor and you inhibit the spiking of dopamine in the vesicles, and then you reduce the amount of dopamine being released to the vesicle, to the synapse. Because we believe highly dopaminergic function plays a role in the chorea symptoms of HD. By doing this, you kind of like reduce the amount of dopamine function, and so you can hopefully relieve the symptoms of chorea. Another approach is to use dopamine receptor blocking agents and similarly to reduce the dopaminergic function. Wilson's disease is an autosomal recessive hereditary disorder, and the defective gene is on chromosome 13, which coding for a copper transporting ATPase is an enzyme, and the defect and it causes defective in copper transportation, but with normal intestinal absorption. And the net effect of Wilson's disease is that you will see excessive copper deposition into susceptible organs such as liver and brain, which causes tissue damage. And commonly, it can present with a liver disease in younger patients, neurologic symptoms in older patients with Parkinsonism, dystonia, tremor, ataxia, and dysarthria. Other organ systems can be involved, including iris, and this is the so-called KF ring because of copper deposition in the iris, fingernails, joints, kidneys, and this is the Wilson's disease's brain with abnormal signal in bilateral head-coated and the putamen, and this is the midbrain copper deposition give you a panda sign, and which is characteristic for Wilson's disease. The treatment for Wilson's disease is to remove excessive accumulated copper by using copper chelation therapy with penicillinamide or trientine, or to prevent its reaccumulation by avoiding copper-rich dietary component or using zinc ingestion medication, because zinc kind of compete with copper absorption. If you take zinc, likely the copper will not be absorbed with less amount of in the system. All right, this is just a quick review of non-PD Parkinsonism. Please let me know if you have any questions. Thank you.